Hello everyone, thank you for coming. Welcome to NADO's 38th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments in the chat and questions in the Q&A. We hope you will take advantage of this opportunity to engage with our speakers and attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in our daily drawings. Now, let me turn the stage over to Norm Thurston, NADO's Executive Director. Norm, the stage is yours.
Thank you, Erica. It's wonderful to be with you here today. I'm Norm Thurston, NADO's Executive Director. And we're excited to have you for our opening session today regarding the Federal Data Officials Panel. But before we get to that, I've got a couple of things I would like to do. First, I would like to recognize our event sponsors. As you have seen from the first 2 days, we do have many sponsors, and I want to mention them all by name to show our appreciation for them. Our Petabyte sponsor is the California Healthcare Foundation. Our Terabyte sponsors are Friedman Healthcare, Mathematica, Milliman MedInsight, OnPoint Health Data. Our Gigabyte sponsors are Barry Dunn, Comagine Health, Equanim Technologies, HSRI, Medicasoft, and the Peterson Center on Healthcare. And our Megabyte sponsors are the CareQuest Institute for Oral Health, Mercer, Optum, and the United States Census Bureau. Of course, we have several sustaining partners as well that do great things and help us continue to provide fabulous programming for our NADO members. And I couldn't do this without mentioning that as much fun as it is to be with you virtually, and I've had a great time, and I've got to meet several of you in the networking rooms, we will be again together next May 7th and 8th, 2024 at the Hotel Monteleone in New Orleans, Louisiana. And we hope that that's on your calendars, and watch for an email in the next few weeks so that you can pre-register and reserve your spot so that you can join us there. I would like to also cover a couple of our NADO awards. At our meetings in Boston, we awarded the NADO Rising Star Award to Megan Denham. Megan, as the Georgia APCD Implementation Project Director, Megan has been one of the historic foundational players involved with planning and implementing the Georgia APCD. Through her leadership, she has continuously ensured that the GAPCD will be a robust platform to enhance healthcare transparency, care quality, and resource utilization within Georgia that can be readily understood by various Georgia stakeholder groups. Megan's purposeful collaboration has brought amazing perspectives to the GAPCD project from all areas of the Georgia healthcare ecosystem, as well as from outside of the state. You can read her full citation at nado.org/awards. Now, I would like to introduce you to our NADO 2023 Data Pioneer Award winners. Over the years, NADO has given awards that recognize an individual's contribution to data use or programming at one of our NADO member organizations. In 2021, we settled on the name Data Pioneer for this award. First, we will hear from Starla Ledbetter, who is recently retired from HCI in California. Then we will hear from Kathy Hines from GIA in Massachusetts. Starla?
Hi, I'm Starla Ledbetter, one of the proud recipients of the 2023 NADO Data Pioneer Award. I'm so very honored to be receiving this award. I was very fortunate to be able to spend my entire state career, spent in 29 years, working for the Department of Healthcare Access and Information, beginning with the Discharge Data Program, then standing up the Data Management Office, followed by integrating our many data collection programs and data warehouse, the enterprise into the Enterprise Data Operations Branch, and finally standing up California's first all-payer claims database. I have greatly enjoyed working with NADO and engaging with many of you over the years to move the needle forward, expanding awareness on the usefulness of standards and the impact of the wealth of data that state organizations have to offer. Please accept my sincere thanks and gratitude for this prestigious award. As I move into my next adventure, retirement, I wish you all the very best in both your personal and professional endeavors.
Thank you, Starla, and congratulations again. This time we'd like to hear from Kathy.
I want to say thank you to NATO and its members. I am honored to receive the NATO Data Pioneer Award, not just for myself, but on behalf of CHIA and its predecessors for all the work we have done over the past 40 years to advance healthcare data collection, understanding, usage, and research. As I started my career, our state was just embarking on collecting acute hospital discharge data. Oh, how we and other states have grown. Massachusetts now collects and reports on visit data from inpatient emergency department, outpatient observation, and most recently, behavioral health inpatient records. And of course, we, like so many other states, have fully encompassed the realm of the all-payer claims data. And we aren't stopping there. We're working now to collect data elements from electronic health records. As our data collection efforts have grown, so too has the Commonwealth's ability to measure the performance of its healthcare system and design impactful policies. I have been privileged over my career to work with many talented people within my agency, across my state, and across the country. And so to all of you, I say thank you for the opportunity to work with you and promote healthcare data over the past 4 decades.
Thank you, Kathy. And again, congratulations to all of our award recipients for 2023. Truly remarkable people doing remarkable things. At this time, I would like to formally introduce the next topic. Our daily opening plenary panel will consist of a panel of federal health data officials. This panel is organized by Kenley Money from ACI and Joe Porter from the APCD Council. Kenley Money will be our moderator. So let's go ahead and bring Kenley on stage. Charles? Hey, Kenley, how are you today?
Doing well, thank you.
Ready for another fantastic, jam-packed day of health data speak. So we are ready for it.
It's been robust.
It's been robust. All right, well, Kenley, I'm just going to turn the time over to you, and let's have you take it from here.
Okay. Good morning or afternoon, everyone. Again, my name is Kenley Money, and I'm the Director of Information Systems Architecture and the Arkansas APCD Director at the Arkansas Center for Health Improvement, and the Chair of the Board of Directors for NATO. So Norm's boss, not really. I am pleased to moderate today's opening plenary panel. Our panelists represent key federal agencies that specialize in the packaging and use of health information. Health information data and its use is very nuanced. Most of us utilize dated and/or point-in-time data to address questions, but in the last few years, the need for real-time health information has become incredibly important. And today's panel will discuss data solutions and assets and plans from their areas that will support our ever-changing work in health policy and with health data. I'm going to briefly introduce our panelists today, and then in the order that they will appear. And Charles will, is when I'm through, then Charles will switch over to the first. Our first panelist is Nancy Belew, Associate Deputy Assistant Secretary for Health Policy in the Office of the Assistant Secretary for Planning and Evaluation at HHS. Boy, I got that. I hope I got that right. Dr. Herbert Wong, Director of the Division of Statistical Research and Methods at AHRQ. Niall Brennan, Senior Advisor for Data Strategy to the CDC Director. And Dr. Victoria Udalova, my apologies, Director of the Enhancing Health Data, or eHealth program, and is a Principal Economist at the U.S. Census Bureau. So Charles, why don't we turn it over to Nancy?
Terrific. Thank you, Kenley, for that wonderful introduction. And to Norm, I'm very happy to join you today to kick off the federal panel. So I think we'll pull my slides up. And while we're doing that, I'll just tell you a little bit about what I'm going to do in my talk. I'm going to talk about our office in AFSI, the role that we play in the department. I'll have some quick examples of the type of work that we do. And then I want to do a deeper dive into some of the data building activities data capacity building that we do in the department. And I'll talk a little bit about one of our projects working with NATO and states who are working on APCDs, and I'll turn the microphone over to my colleague, Herb. So we'll move to the next slide. If we can, I'll just say a word about who we are in the department. So we advise the secretary on a whole range of topics, right? Health, disability, any number of topics that the department is working on. We lead special initiatives across HHS with our colleagues in other parts of the government, et cetera. So I won't read all the items on this slide. We'll move to the next slide. And I'll tell you that we work across HHS agencies. This lists them. As you all know, we are a big department. So we'll move to the next slide. And this is an example of the work that we do across agencies. We work on maternal health. We've done that for a number of years now. We've worked with our colleagues at the White House and with other departments. The White House released a blueprint a year ago, June. The work that we're doing on maternal health, like much of the rest of our work, relies on data, much of which states gather and report, and we use to help inform our policy making in the department. We'll move to the next slide. The next slide is an illustrative example of other work that we're doing, again, across the department and with our colleagues in the White House. So we have convened all the agencies that I showed you a few moments ago. We've developed an action plan for the department to address social determinants of health. We all know how important it is to connect our health and social care systems. Our White House colleagues have convened a government-wide work group. We have a number of documents at the web link here that describe our work, and we have more documents that will be coming out shortly about our work in the department and our work with our colleagues across the department. So we'll move to the next slide. And I want to do a little deeper dive. Some of you may know about a funding source we have in the department, but many of you may not. It's called the Patient-Centered Outcomes Research Trust Fund. So that's a great big title. It was initially enacted in the Affordable Care Act. What it calls upon the Secretary of HHS to do is to build data capacity for comparative clinical effectiveness research. Our office in ASPE, we work across the department to fund data projects. And I have some illustrative examples of some of that work that I'll talk about in a moment. I just wanted to start by giving you the guidance that we've received from the Congress. So we'll move to the next slide. We were quite lucky in 2019 that Congress reauthorized the trust fund for an additional 10 years. You know, so much of our work in the department, we don't have a 10-year dedicated funding stream that we know about, 10 years in advance to do our planning. So we're very fortunate that we have that runway with the Patient-Centered Outcomes Research Trust Fund. We have funding through 2029. So when the Congress reauthorized the trust fund in recent years, we then worked inside the department and with stakeholders outside the department to develop a strategic plan. What are some of the most impactful projects we can do in HHS using this funding source? I won't walk through all the parts of the strategic plan here. I just wanted to put them up for your awareness. So we'll go to the next slide. This is one example. We have about 35 to 40 data projects that we have underway in any given year. So we have many different projects we are doing to build data capacity. This is an illustrative example. The use case here, the policy problem we're trying to inform, is the nation's opioid epidemic. What we're doing here is linking data from a variety of sources. The National Death Index, we obviously get from the states, vital statistics, birth certificate information, death certificate information. My colleague Niall and CDC, they pull that information together and make it available for various purposes, research purposes. We've linked a number of data sets. And what I want to draw your attention to here is that our products are all available on our website. So I've got a link here to this particular product, and then you'll see many more available as well. We want to make sure people know about the great work that the agencies are doing across the department. So we'll move to the next slide. And maybe advance again. So we've got more content on here. Yeah, and you can put the whole slide up. That'd be terrific. So this is an example. We've done a lot of work over the last several years in the National Death Index. working with our colleagues in CDC, working with state officials to try to improve the timeliness of that information, the accuracy of that information. Many of our agencies in the department, FDA, NIH, CMS, and others, really rely on this information. So this is another illustrative example of some of the projects that we are doing using the PCOR funding. We'll move to the next slide, please. And then I want to spend just a moment on some work that we've been doing in partnership with a number of states, including hopefully many of you who are listening to the session today. We've been working with Joe Porter, with Norm, on other colleagues in NATO to try to look across states. How might we be supportive of using the data for a number of national challenges, national health challenges? So we have a report that we've just put up on our website. I'm drawing your attention to that report here. It's the third in a series of reports about opportunities with APCDs. We'll move to the next slide. Some quick key takeaways from that report, some of the challenges with state data, some of the opportunities, and we are looking to continue our partnership in working with states to address some of the challenges. We'll move to the next slide. And then we've got a number of promising developments that we're highlighting, both in that report and in some of our discussions with states. I'm queuing this up because my colleague Herb will talk a bit more about some work that we're doing in partnership with our colleagues in AHRQ. So we'll move to the next slide. And I'll just say thank you for the opportunity to join this panel. This is a view from our building, a view of the Congress, obviously. I welcome anyone who wants to reach out. I've got my contact information here on this slide. And then I also have I have the website for additional information about our many data projects that we're using the Patient-Centered Outcomes Research Trust Fund to finance. So thank you for the opportunity to join the panel today, Kenley.
You're welcome. You're welcome. Let's move to our next panelist, Dr. Herbert Wong.
Thank you, Kenley. So as my slides come up, I just want to remind folks, my name is Herb Wong. I am the Director of Statistical Research and Methods here at the Agency for Healthcare Research and Quality, also known as AHRQ. Just by way of background, I am trained as an economist, and I've spent my career really creating and disseminating databases, as well as conducting healthcare policy research. So for the next 10 minutes or so, I'd like to provide you with a thumbnail sketch of some of the data development activities that AHRQ has been engaged in. Broadly speaking, AHRQ is well aware of existing data resources are really insufficient to address some of the emerging policy issues, and AHRQ has taken some steps to really close that healthcare data gap. Next slide, please. And so AHRQ is one of 12 operating divisions within the Department of Health and Human Services. As you can imagine, each operating division has a different area of focus. For example, NIH has a tendency to focus on clinical research, CDC focus on population health, CMS focus on payment incentives. AHRQ's focus is on research to deliver safe and effective healthcare. Next slide, please. So for AHRQ to achieve its mission, AHRQ has three really core competencies. Health systems research, where AHRQ invests in research and evidence to make healthcare safer and to improve quality. Practice improvement, where AHRQ creates materials to catalyze improvements in healthcare. And data and analytics, where AHRQ generates measures and data to improve the performance of the U.S. healthcare delivery system. So I'm going to talk a little bit more about AHRQ's core competency in data and analytics. Next slide, please. So AHRQ has really had over 3 decades of experience building and disseminating research databases. The agency's flagship data programs are the Medical Expenditure Panel Survey, or MEPS, and the Healthcare Cost and Utilization Project, HCUP. MEPS has 2 major components. One is an annual survey of households about their health care, and the other is an annual survey of public and private employers about insurance coverage. Now, Many of you may be familiar with HCUP, which is a collection of hospital-based discharge data in the inpatient, emergency department, and ambulatory care settings. Now, MEPS and HCUP are really terrific resources that can be used to address a range of healthcare policy issues. But the healthcare environment continues to change and to evolve, and new policy issues are constantly emerging that cannot be answered or addressed with these data sources. So there's really no perfect database. All the databases have strengths and weaknesses, and there's a general recognition that data resources need to be continuously enhanced, and that new innovative data resources really need to be created. Next slide, please. So for the last several years, under an umbrella that we call ARC Data Innovations, ARC has made some progress in filling these data gaps. So I would like to just mention 3 of the new data resources here. The first is what we call the Synthetic Healthcare Data for Research. The acronym is pronounced CIDR, as in apple cider. And this database is a nationally representative insurance claims database that has been de-identified to protect privacy and confidentiality. The second data resource that we have is the Physician and Physician Practice Research database. The acronym is pronounced 3PRD. And this database captures the census of physician and physician practices in 13 prototype states. The database includes physician and physician practice characteristics that are useful for analysis. And finally, the third data resource that ARC has created is the ARC Social Determinants of Health, or SDOH database. Now, this database includes information on characteristics of the communities across the US under several different domains. Now, all of these databases are available to the public free of charge. The CIDR database requires a data use agreement to be signed, but the current version of 3PRD and SDOH databases are public use files. An enhanced version of the 3PRD file is forthcoming and will require a data use agreement. And you can get more information about these databases if you go to the ARC website and search under ARC Data Innovations. Next slide, please. So the most recent data development area that the agency has been engaged in is in the insurance claims data space. In the President's fiscal year 2024 budget, $7.4 million was included for ARC to regularly create and disseminate a national all-payer claims database, APCD, which is nationally representative sample of health insurance claims data. For this to move forward, funds have to be appropriated by Congress, and so we have to let that process kind of plays itself out. So let me make a comment of what is meant by national APCD. And the big point that I would like to highlight is that the term national APCD means different things to different stakeholders. The term itself implies a census of health insurance claims data, and that is from all payers and for all of their claims. So the emphasis that I want to place here is that from ARC's perspective, we are not envisioning all payers. We are not envisioning all claims. We are not envisioning a census of claims. Rather, our vision is a nationally representative sample that is sufficient in size and completeness to inform the most pressing policy issues. So let me illustrate this a little bit. So the ARC's MEPS household survey samples approximately 10,000 households to represent 125 million households that are in the US. This is just 8 1,000ths of a single percentage point of all households in the US. So that's a very small fraction. Another example would be the ARC HCUP National Inpatient Sample, which is a sample of approximately 7 million inpatient discharges to represent roughly 35 million inpatient discharges that occur in the US every year. And that's a sample of about 20%. And finally, the CITER database that I mentioned a little bit earlier is a sample of 18 million beneficiaries to represent 330 million people in the US, which is roughly 6% of the population. So my main point here is that you don't need a census of insurance claims data to produce a research database that is useful for analytic purpose. Even with a small sample, with the right sampling and the right weighting approach, you can really create a powerful and useful database to kind of produce that. Next slide, please. So as the federal appropriation process kind of takes place, and as Nancy mentioned a little bit earlier, ARC and ASPE are eager to kind of get started and have worked together over the last several months to develop a prototype insurance claims database. ARC and ASPE now have an agreement in place to move forward on a project that we call Panoramic View of Patient Care Through Data Innovations and Linkages. The product information is listed on the ASPE website, and the URL is kind of highlighted on this slide here. Now, because funding for this project is from the Patient Centered Outcomes Research Trust Fund, or the PCOR Trust Fund, the database is going to be designed for PCOR and clinical effectiveness research. The prototype that we are investigating here falls short of a national APCD. It will have a state level focus. The prototype that we're envisioning is really a proof of concept of a new data infrastructure that potentially a national APCD can be built from. The database will capture information that is typical in a claims database. There will be information on the medical care of patients in the inpatient and ambulatory care setting. There will be information on office visits and pharmacy. There will be information on beneficiary enrollment. Now, to capture the 360-degree or panoramic view, the state level databases will include information on the characteristics of providers and such as physicians and physician practices, as well as other non-clinical factors such as the social determinants of health. And finally, there will be a public dissemination component for these databases. Next slide, please. So throughout this conference, we learn a lot of different ways by which data owners have shared their data, including different federated models. The model that ARC is prototyping here is what we call the federal stewardship model. And in this model, ARC is viewed as a trusted data steward. And as a trusted data steward, ARC establishes data partnerships with federal, state, and private entities, and that may maintain insurance claims data. ARC would receive these data under some sort of data use agreement or memorandum of understanding. ARC is then responsible for harmonizing, standardizing, performing standard quality control checks on the data. And finally, ARC would then create research databases. Now, as I mentioned before, this is a prototype that focuses on the state level. So the databases will be built for a handful of selected states. But the potential here is that in the future, a national level database can be built by sampling these state databases that we're kind of investigating here. So finally, an important feature of this project is to make sure that researchers gain access to these databases. And to disseminate the databases, there are different possibilities in terms of dissemination mechanisms that we're envisioning. We're envisioning a public use file or a PUF file where information is totally de-identified and that may be easily posted. a restricted use file or rough file, which is governed by a data use agreement. And finally, for the most sensitive data elements, perhaps data access through some sort of secure data center. So the roadmap that we're painting here is really based on our experience with the healthcare cost and utilization project, and many of you may be familiar with the entire HCUP partnership. Next slide, please. So at the core of this project is the establishment of data partners. Entities that maintain state APCDs are clearly important potential players in this endeavor. The state APCD community has been growing and becoming more sophisticated and have rich experiences. However, state APCDs are probably painfully aware that their data are often incomplete for a variety of reasons, including ERISA laws. It's important to establish other data partners to kind of fill in these data gaps. So we know that there are many commercial claims data vendors who may potentially serve as a data partner in some capacity. There are many federal entities that maintain health insurance claims data, such as CMS for Medicare and Medicaid. And there are probably other federal entities that claims data may potentially be leveraged. So an important component of this endeavor is to create what I call the win-win situation. Next slide, please. So let me highlight some elements that may be viewed as a win-win. What is the value of to the data partners for participating in a project like this? From the data partners' perspective, a new data resource that is representative of their own state population may help them, in fact, benchmark their own data. There are data gaps in most state APCDs, and can participation in this endeavor help kind of fill in those data gaps. Participation in a federal project may showcase the value of their own data programs to their own constituents. And harmonized and standardized data may help facilitate multi-state comparisons. And finally, if the project grows and becomes a program, products such as reports and other data tools may be developed to benefit the partnership overall. Next slide, please. So one of the challenges facing the federal government is that policy will be made with or without information. And the pandemic really highlighted the fact that healthcare data gaps still exist. And the federal government is well aware of these data gaps. From the federal perspective, this is a win because the project will begin to fill in an important data gap. It complements existing data resources and provides a new data resource to inform emerging public and private policy. So it provides a new data resource to the research community where evidence can be generated to inform policy. And in the future, this can be expanded to include national representation. Next slide. So with that, I thank you for your time, and I look forward to our discussion. And I'll turn it back to you, Kenley.
Thank you, Herb. That was great. I want to introduce our next speaker, Niall Brennan. Niall, are you ready?
Yeah.
All right, take it away.
Okay, thanks, Kenley. Hi, everybody. It's good to be here. Guess it's been a while since I've checked in with NATO. I joined CDC about 3 months ago. I like to refer to myself as the world's highest paid public health intern. I'm learning a lot. I think from a big picture perspective, you know, the agency has been through a lot over the past 3 years. The pandemic fairly cruelly exposed lots of things related to how we respond to them, but particularly CDC's ability to deliver real-time insights was, you know, pretty problematic, and kind of embarrassing when you have organizations like Johns Hopkins, and they did great work having to stand up a COVID dashboard because CDC was incapable of doing it. So Congress recognized that there needed to be significant investment in CDC's data infrastructure, so we could avoid these kinds of things going forward. And really, there's a ton of detail and nuance, but essentially what we hope to achieve over the next 2 to 5 years is plugging public health into the healthcare system, arguably for the first ever time. And we want to do that by using the modernization funds that we've gotten and building on the generational investment that we made in health information technology, particularly in our nation's hospitals, and connect the public health system to the hospital system so that data will flow. I do have some slides here. I'm going to be totally candid. It's really hard for me to see them because it's not in full screen. But I think that first slide, more or less articulates what I was saying. The data is dirty. Epi spend far too much time cleaning data. It takes too long. Not all of this is a technology problem either. A lot of it is data governance, a topic that you all will be very familiar with, but it's a very complicated set of rules and agreements between CDC and the states and state and local health departments. So that all can take just far too long when you're in an emergency response situation. So that's the slide kind of articulating a little bit of the problem. Next slide, please. And this is, oh no, there were two versions of a similar slide. There we go. And so this is future state where data flows seamlessly from healthcare providers through state, tribe, localities, and territories, and then as appropriate and generally in a de-identified way to CDC. So that CDC can inform the public. And, essentially we are viewing public health and public health data as a national security issue. So if you don't have real-time visibility and situational awareness into what's going on, you are almost immediately at a disadvantage. Next slide, please. So overall, the public health data strategy goals are strengthening the core of public health data, accelerating access to analytic and automated solutions to support investigations, visualizing and sharing those insights, and advancing more open and interoperable public health data. Next slide, please. So what I've found since joining CDC is that it's kind of fascinating. It's a classic government problem where the money tends to be funneled towards disease-specific solutions. So and so there will be a system built for sickle cell, and a system built for flu, and a system built for asthma, and a system built for injuries. And so CDC has ended up with this a proliferation of systems, over 1,000 actually. And so a lot of them are, using dated technologies. The data is very difficult to share even internally at CDC. A really important point is that it's creating a really heavy burden on providers. If you just look at information on a condition-specific hospitalization information, we're basically collecting that data in 5 different ways through 5 different systems. And these are systems that I literally never heard of, having been in health data for a very long time. So I think our provider partners are rightfully starting to push back on CDC, particularly because some of those data collection mechanisms are fairly onerous and manual. Next slide, please. So essentially, what we're trying to do is, this is very much, like the data lifecycle stuff that I used to articulate at CMS. You've got data collection, data architecture and storage, data analytics, and data dissemination. This is basically a variant on that. But if you don't start off with the right data, this audience knows that better than anybody else. You're going to struggle with everything else, because you're going to have a little bit of a garbage in, garbage out problem. So is there another slide? I'm not sure if there is. So that's kind of the end of the slides. What I'd say is there's a ton of really cool stuff happening at CDC, and it's just absolutely fascinating for me as a healthcare system data person to start to explore and understand this world of public health data. The agency is really committed to making these changes. They've established what is essentially an enterprise data office at CDC in much the same way that that CMS did back in the day. We're hiring. If anybody wants to work in a fast-paced yet slightly dysfunctional government environment, please let me know. We've hired lots of amazing folks from the private sector to try and start to push the needle and actually implement and build things. There's incredible innovation around microbial resistance issues, and my new passion project is poop, wastewater surveillance. It is the one thing that America in the public health sphere does better than anybody else in the world. So I'm working very closely with the with the wastewater team to beef up their analytics and really make that data more compelling and hyper local. We can measure COVID, monkeypox, flu, RSV, and a whole list of other viruses whose names I can't remember through wastewater. So I think that's going to be a real benchmark program for CDC going forward. And what it does is it fits into a continuum of information. So wastewater is sort of our earliest warning system, and we have research that shows wastewater peaks are followed closely by lab positivity peaks, emergency room visits, and then eventually the hospitalizations, and unfortunately in some cases deaths. So that's the kind of situational awareness we're trying to build. We've also established a new center for forecasting and analytics. Prior to COVID, CDC was completely dependent on essentially mostly voluntary academic forecasts of what specific seasons, flu seasons would be like. And so we've built our own internal forecasting capacity to develop those models ourselves for COVID flu, RSV, and other activities. And then we're incorporating things like wastewater data. So I just actually sat down with the team before I get on this call, and they were illustrating to me the incredible predictive power on hospital utilization when you factor in wastewater data. So I can stop there. I'm happy to answer any questions. I realize this might be a little out of left field for an auto crowd, but maybe not. Maybe it's totally on point. So thank you.
Thank you, Niall. I love that your project is poop. But at the end, you wove it all together when you talked about what you would look for in wastewater systems and how it could negatively impact
Totally.
ultimately.
Yeah, and so I mean that's just why it's so fascinating to discover this whole world of other data. And my final thing is the informal nickname for the new really cool external dashboard we're building. We call it Poos Clues. So.
Okay. Thank you, Niall. Questions later. Let us move to our last speaker, Victoria. Take it away.
Thanks, Kenley. Hi, everyone. My name is Victoria Uralova. I'm the director of the Enhancing Health Data or eHealth program at the U.S. Census Bureau. Today, I'll describe the role the Census Bureau's data and record linkage infrastructure play in facilitating the production of statistics and research of interest to the broader health data and policy community. I'll provide a few specific examples of our ongoing projects and partnerships where we enhance health data with census microdata. Next slide, please. Let me start by motivating the need to enhance health data and why it is crucial to do so now more than ever before. I will be brief, as I know the audience is already familiar with some of what I'm about to say, but just to level set. A large share, almost 20% of our economy is tied to healthcare. Not only is healthcare such an important part of our economy, but the US healthcare system is also extremely complex, and its structure continues to rapidly evolve. To describe this complex structure and this complex system, we need different data. We need to rely on multiple sources of data, and with greater availability of health and other administrative records, it is now more feasible than ever before. Next slide, please. Given this exceptionally large investment in healthcare spending, how are we doing in terms of actual health outcomes? As most of you know, the answer is that we're not doing so good. Our life expectancy is significantly lower than other comparable countries. The gap has also been growing over time, and it increased even further during the pandemic. And the problem is we don't fully understand why. More recent research is showing the importance of social determinants of health, conditions and factors outside the healthcare system itself. In order for us to understand the causes behind this trend, we need data on income, education, access to transportation, health insurance, housing quality, access and quality of food, and these elements are rarely found in health records. But these elements are available at the Census Bureau from a variety of surveys and administrative records. Next slide, please. Let me now explain the data assets and the record linkage infrastructure available at the US Census Bureau, which can be used to fill in some data and knowledge gaps. The Census Bureau is the largest federal statistical agency in the country. We have a significant collection of data sources which can be used for statistical purposes. First, the Census Bureau has data it collects directly from individuals and businesses via multiple surveys and censuses. For example, we have demographic data from decennial census, which is conducted every 10 years and collects basic demographic information on individuals living in the United States. Or the American Community Survey, the largest nationally representative household survey conducted by the Census Bureau, which contains information on income, education, occupation, housing, and other social determinants of health. or the economic census, which is conducted every 5 years and collects information from businesses in the United States. Second, we have several important frames that we use for our survey and census operations, as well as for research. For example, our master address file, or MAF database, provides a complete list of addresses in the United States, and when combined with other data sources, allows us to identify residential locations of individuals over time. Or the business register, a comprehensive listing of all business establishments in the country, along with their characteristics, which has been continuously updated since 1972. We are also compelled by law to use administrative and other existing data to the maximum extent possible instead of conducting direct inquiries. As such, the Census Bureau acquires administrative records from state and federal agencies, third parties, and private sources. For example, we have data from the Social Security Administration's Numident file, which contains dates of birth and death for nearly universe of the US population, or data from the Internal Revenue Service, IRS, that provide a rich source of income information. We also have program participation records from state SNAP, WIC, and TANF programs that provide enrollment and benefit information for those participating in those programs. We have additional business records, such as the longitudinal employer household dynamics, or LEHD data, which are based on states' unemployment insurance records and census microdata, and provide information on employment and earnings. In terms of health data, we currently have Medicaid and Medicare enrollment records, some Medicaid claims, and electronic health records from our external partners. So as you can imagine, this is a powerful set of data sources. Next slide, please. Oh, I think the one before. Oh, sorry. No, yep, perfect. Thank you. Our survey, census, and frame databases provide a useful base to which additional administrative records can be added. We're able to combine all these data sources using our internal record linkage capabilities. Every new data set ingested by the Census Bureau contains personally identifiable information, or PII, such as social security numbers, names, dates of birth, which allow us to assign internal anonymized Census Bureau linkage keys by finding these PII elements in the internal reference file, which you can think of as an agglomeration of multiple survey data and administrative records. These anonymized internal linkage keys are common across data sources and are consistent over time, allowing researchers to identify the same set of individuals in various data sources. After matches are found, PII get dropped so that internal and approved external researchers can only have access to data with anonymized identifiers and thus do not have access to identified data. All restricted microdata must remain within the Census Bureau's secure firewall. Microdata can only be used for statistical purposes, and all aggregated statistical output is reviewed for disclosure risk before it is approved for public release. We follow the terms in our data use agreements, which restrict data uses to only those authorized in the agreement and only by authorized individuals. Next slide, please. So can these rich data assets and record linkage capabilities be used to enhance health records? Well, we think so. The Census Bureau's Enhancing Health Data, or eHealth, is a research program where we identify existing data gaps which can be filled by enhancing health records with existing data assets uniquely available at the Census Bureau. An important component of our work is our ability to rely on census population level data. Health records are rarely representative of any population. Having access to population level data allows us to assess representativeness of patients captured by health records, as well as to assess representativeness of providers relative to communities they serve. Next slide, please. We have projects that fall under the broad bucket of demand for healthcare. This is the patient side of eHealth, where we focus on creating products and conducting research on social determinants of health. We attach demographic and socioeconomic characteristics to health records using census data. We have several completed and ongoing projects in this bucket. Next slide, please. In partnership with Utah Department of Health and Human Services, we linked emergency department visits to the American Community Survey at the individual level and created new estimates of emergency department utilization by social determinants, focusing specifically on preventable emergency department visits. Next slide, please. Through our partnership with the University of North Carolina, we linked patient-level electronic health records to the American Community Survey and assessed the feasibility of further EHR census data linkages by examining linkage and match rates. We are in the process of expanding our partnership to link clinical information from EHRs to census microdata. Next slide, please. We are also partnering with the American Board of Family Medicine, ABFM, and Stanford University to link EHRs from family physicians across the country to census microdata. These EHR data are submitted to ABFM from participating providers as part of the PRIME registry. Stanford University curates this data on behalf of ABFM, making it easier for researchers to work with the data. We have ingested a subset of these records into the Census Bureau's data linkage infrastructure and are in the process of answering several research questions focusing on social determinants of health in the primary care setting. One of our research questions also focuses on validation of several publicly available area-level social deprivation indices for their associations with health outcomes and person-level demographic and socioeconomic measures. Next slide, please. We have also recently released a new working paper describing our efforts to enhance race and ethnicity information in Medicaid data. Medicaid data contain a high rate of missing race and ethnicity information, and the rate varies significantly across states. Through linkage of national Medicaid administrative records with census microdata, we evaluated the impact of missing race and ethnicity information on estimation of race-specific all-cause mortality, assessing any potential bias due to missing data. Next slide, please. We have also recently published a research paper that uses enhanced Medicaid claims data. In this project, we evaluated the relationship between income and health using Medicaid claims data linked to the American Community Survey and census numerant mortality administrative records. We found that among children and adolescents, higher family income is associated with a lower prevalence of diagnosed infections, mental health disorders, asthma, and mortality. Next slide, please. Our team has also produced several research papers linking survey and administrative records to document differences across demographic and socioeconomic groups in economic and health impacts of the COVID-19 pandemic. This work found that the impacts of the pandemic on all-cause mortality and unemployment were concentrated in the same racial, ethnic, and education groups. Next slide, please. Now turning to the supply side of healthcare, or the provider side, we are currently working on the physician component of the health frame, developing a new framework for linking multiple existing data sources on physicians and their places of employment. This project leverages our unique data assets to fill in a gap in supply side data on characteristics of providers in terms of race, ethnicity, employment status, and earnings, and their practices in terms of geography, business structure, revenue, and ownership. Next slide, please. One of our already completed projects provides new estimates of physician earnings and describes physician income misreporting in our survey data. Next slide, please. While currently we are working on supply and demand side projects in parallel, developing a set of experimental health frames, whether for patients or physicians, our ultimate goal is to integrate the two sides, to create an integrated health frame, to allow for even more detailed data to improve our understanding of the US healthcare system. In everything we do, we rely on our partners for health records and their subject matter expertise. Jointly, We draft data use agreements that frankly sometimes take longer to sign that either party wants, that specify how health data can be used and by whom. At the Census Bureau, protecting data and privacy is a top priority. While access to restricted microdata is limited to authorized users who need it to generate statistics or to conduct research, our goal is to produce public-facing data products and research findings, allowing a wider range of users to access the information. We are currently innovating to identify best solutions for data sharing and secure record linkage, such as exploring cutting-edge tools for secure multi-party computing, as well as latest disclosure avoidance methods to preserve individuals' and businesses' privacy. And let me just conclude by saying that I'm optimistic about the future and our ability to utilize the Census Bureau's unique data assets and record linkage capabilities combined with health records to create useful statistics and to allow researchers to answer important policy relevant questions. Next slide, please. Here's my contact information, and thank you so much for your time.
Thank you, Victoria. As always, it's fascinating. Charles, could we bring all of our speakers on stage? All right, there's Nancy. All right, thank you so much, panelists. It was very interesting. It's always fascinating to me how uniquely your groups are, and yet how it's all woven together, because all of the data, all of it touches each other. Charles, are there any questions out there from the audience? Karen Lee. Karen Lee Harrington writes, one significant data gap is the data that payers are redacting from their APCD submissions per their interpretation of 42 CFR Part 2. Any update on this issue and how we might be able to work together to address this would be helpful. Dr. Wong or Nancy? I'll start with you.
So I'll just note that's a great question, and I don't have a specific answer to it right now. We appreciate the concern. So I think I'll leave it at that. I don't know, Herb, if you have anything to add.
I think the only thing we'll add is that we are in conversations with the Department of Labor to kind of try to sort out the issues there. So they're a regular participant in some of our conversations.
I should think that data gap might be problematic for the APCD goals that you stated. But anyway, all right, Nate Pauley writes, Herbert mentioned that the prototype national APCD will have a state level focus. Can we hear more about what that means? Will there be different data sets for each state?
Yeah, so so as I mentioned, this prototype is going to fall short of a true national APCD. So in other words, we're not going to build a database that's representative of the nation overall. The state level focus means that we're going to choose a handful of selected states, 4 or 5 states, where we're going to address the issues that is relevant for those states. So for instance, we already know that for most state APCDs, their data is incomplete because of ERISA laws and other reasons that sits behind it. And so the goal here is to produce a state APCD that is truly representative of their own individual state through different methods of sampling, weighting, and really understanding what is it that an individual state is missing. So if it's missing ERISA data, is there a way to fill in those data gaps or understand enough of the missingness to create the correct weights and sample from it to produce a database that might closely reflect what that state population utilization might be? So we're not targeting all of the states. It's only going to be a handful of states, 4 to 5 states for our initial prototype.
Another question, Everin Page writes, adding to Nate Pauley's question, I would be curious to know how the national APCD will handle states that don't have an APCD. Will they obtain directly from the data directly from the insurers, or will those states not be represented?
Yeah, so that's a terrific question. So the example that I will give is the synthetic healthcare database that we produce and I have mentioned earlier. In that particular database, we produce a national claims database that has been de-identified, but it was nationally representative. And so in that situation, we obtained data from CMS to reflect Medicare and Medicaid, and also commercial data that to kind of round out all the payers. Now, suppose you have a situation where there is no state APCD, right? And is there a way to produce a state level database? The short answer is that from a sampling perspective, you can actually do that. You can use, say, CMS data to reflect the Medicare and Medicaid components of that. And you can also leverage, say, commercial data from other vendors, whether it's directly from the insurers or other data vendors that might actually have that. You hone in on a state that might not have a state APCD, but through the correct sampling and weighting strategy, you can in fact build something that would be representative of that individual state. So, so that there's a possibility there to even go beyond that.
Sylvia Hobbs asked, to what extent does the Census Bureau leverage its linkage methods and data imputation with the artificial intelligence tools, and what type of AI tools are you using? Victoria?
Yep, thanks for your question. So I'll just say, like, very briefly, the Census Bureau is a very large agency, but our record linkage methodologies, as well as the use of our artificial intelligence tools right now is a hot research topic. So all program areas around the Bureau are experimenting and researching those tools and methods. I'm not going to give you a specific list right now, but every area around the Bureau is exploring a different way of it's if you think about surveys, right, there's a whole life cycle of surveys, right? So each phase of that life cycle we're experimenting with different methods.
Thank you. Victoria Razin, question for Herb Wong. How can state APCDs become data partners with AHRQ for the national APCD?
Yeah, that's a full question. So I would say that we are beginning the conversation. As you know, I kind of mentioned that we are in partnership with ASPE in terms of the prototype model. We're going through procurement processes as we kind of speak now. But I would love to hear more from state APCDs that might be interested. I think that the best way to do that is to contact me directly, and I could have a conversation of what I may be anticipating in the future as this procurement kind of plays out.
Okay. No questions. So, oh yes, here we go. Ryan Christensen, question for Victoria. Is the master address file data publicly available? I had the same question.
Yeah, good question. It is a restricted internal database that we have. Kind of the infrastructure that I was describing to you basically uses all of our restricted data with the idea that we can then create publicly facing products that are of value to our data users. Access to the microdata, researchers can, for certain purposes, also get access to the restricted microdata. There's a whole process for that. But you cannot just, go on our website and find access to, you cannot access math database publicly.
It's tough. So Norm posted, we have time for one more question. And if there's not one, I have one. All right. So Dr. Wong, tell me, oh, wait. Thank you. You have the CIDR file. Why do you need a national APCD?
Yeah, so the CIDR file is it was really a proof of concept in many ways, and it is a national representative data, but there are shortcomings with all databases I have mentioned in my component there. So we proved that it is possible to build it, but we want to improve the quality of the data. And that was a prototype that was built in 2000 using 2016 data. As everyone knows, policy is developed on the most recent data. And so that proof of concept is, hopefully will spill over to this greater effort where we can have a consistent data program that continuously feed the field and to be used in other resources.
Okay. Thank you very much, everybody. Great discussion. And Charles and Norm, I believe we're on time.
Yes, thank you, everyone. This has been a fantastic session. I've loved the engagement with the audience, and I think what comes out of this is that we have more questions that we need to explore further, which is always a great part of kind of having these sort of scientific reviews of what's going on. So thank you all again, and we will see everyone in just a few minutes over at our breakout sessions. Bye-bye.
Thank you, everyone.
Yep, thank you.